Good evening, everybody, and welcome to this very special event for Good Grief Festival. And I'm joined today by Doctor, writer and campaigner, Dr Rachel Clarke. Hello, Rachel.
Hi, Lucy, and hello, everybody. It's amazing to see where everyone's from and their experiences popping up in a huge stream.
My name's Dr Lucy Selman. I'm an associate professor in palliative and end-of-life care at the University of Bristol, and I'm the founding director of Good Grief Festival. Before I introduce our guest, I just wanted to go through some housekeeping. So this session is going to be 1 hour long, and you can join in the discussion today in two ways. So as we've said, you can let us know where you're watching from and share any reflections or thoughts in the chat. You can also write your questions in the Q&A box at the bottom of the screen, and we will be taking questions from the audience towards the end of the event. And you can find the chat and the Q&A icons at the bottom. So just click on there and you can write your questions or your chat in there. There's also a new function in Zoom, which is the resources. So if you go to the resources tab at the bottom of the screen and click on there, you'll be directed to a range of different resources and links, which we'll refer to in the session today. This session will cover some sensitive topics, so please do take care of yourself and leave the webinar if you need to. And the resources are there also as sources of support and signposts to other support that's out there as well. So please do have a look at those. So without further ado, this evening we're joined by Dr. Rachel Clarke. So formerly, Rachel was a current affairs journalist and she qualified as a doctor in 2009. Her best-selling memoir about life as a junior doctor, Your Life in My Hands, was published in 2017. And her second book, Dear Life, was published in January 2020. And I had the honour of talking to Rachel about that book at our first festival in October 2020. And that book explores death and dying and end-of-life care and her own experiences of grief after the death of her father. It was shortlisted for the 2020 Costa Book Awards. And then her third book, Breathtaking, was published in January 2021. And it's based on her own experiences caring for patients with COVID-19, as well as providing palliative care during the pandemic, and also on interviews with colleagues and patients and their families. And it really reveals what life was like inside the NHS during the first wave of COVID-19 in the UK. And the book, as many of you will know, and presumably that's why you're here if you've watched it, it was recently dramatised and shown on ITV as a 3-part series, which Rachel co-wrote with Jed Mercurio and Prasanna Puwanaraja. And this evening we'll be talking about the television series and some of the issues and questions which it raises. So welcome, Rachel.
Thank you very much.
First of all, congratulations on the huge success of Breathtaking and the way in which it's really brought into public conversation exactly what it was like, the truth of what it was like for clinicians working through the pandemic. So thank you for doing that. I wanted to start with just a general question, really, which was, what were your main aims in creating the TV series after you'd written the book?
Well, I think I was aware that this was an incredible opportunity. When something appears on our television screens, you're able to kind of beam into people's living rooms, people's consciousness, a story in a way that has much more potential power to move and engage people than even writing a book, let alone a newspaper article, say. And I just had a really simple, but I think quite ambitious aim. I wanted the series to depict completely truthfully and honestly and accurately what it really felt like, what we saw, heard, experienced in NHS hospitals as the pandemic unfolded, with nothing either sanitized or sensationalized. This would not be like a kind of ER or Grey's Anatomy version of medicine. This would be the NHS wards, and all you would see it as we experience it as staff. And I think more than anything else, I wanted people to watch the series and remember what actually happened, and maybe see what actually happened and think about what actually happened for the first time, because the more the pandemic is receding into recent history, the more we have competing narratives, I think very revisionist narratives about what happened. And at the same time, staff have been through this incredibly traumatic experience that I think to many people feels almost buried. No one wants to hear about it. No one wants to think about it now. And yet it felt so important to talk about it.
Mm. And actually, that's something that comes up a lot when talking to people bereaved during the pandemic as well, isn't it? That there's this fear that as kind of, life goes on, that those experiences are forgotten about. And I think that is also an angle in the TV series as well. It's a sort of bringing it all into the light.
Yes, very much so. And I think it's really striking that in 1918, so that around the time of the Spanish flu, again, with that global pandemic, it wasn't memorialized. The enormous loss of life wasn't memorialized. There was very little depiction of the Spanish flu, that global pandemic, in contemporary art, literature, and I almost feel as though, to some extent, the entire population with COVID-19 has been through a traumatic experience collectively. We all lost something. Worst, people lost their lives or the lives of someone they loved dearly, but everybody lost something. Kids lost being able to go to school. We all lost our social lives, our social networks. Crucially, people who were bereaved lost the chance to mourn in a normal way, to have those public rituals of mourning that bring us all together at difficult times, and help us share those experiences. And I think that has made, I think nationwide, I don't think it's an exaggeration to say that to some extent we are all grieving for something that we lost during those awful 18 months, the whole year of 2020, and then the first 6 months of 2021, I think for me are the sort of most traumatic period. And it feels wrong to me now that to some extent, we're almost charging on into the future as though that never happened. It feels almost disrespectful to everybody who's bereaved, to everybody who lost their life, to everybody who found it traumatic. Surely, at the very least, as a society, we should pause and take stock and reflect upon this momentous moment in our history.
Mm. Yeah, I agree. And there's something about having to face it, to face the truth and remind ourselves of the truth as a way of, I think, trying to process what we've all gone through, but especially clinicians and especially people who were bereaved during the pandemic.
I think so, yes. And I mean, at an individual level, in my job in palliative medicine, I often meet people who are traumatized, who are devastated by grief or the grief, the anticipatory grief, what they know is coming to them when they lose the person they love. And it can be really tempting psychologically to try and bury those feelings because they're distressing and refuse to allow them to surface. But of course, there's a real risk in doing that you just suppress something in a way that causes it to fester. It doesn't go away, and it probably comes out at some stage in unpredictable ways. And I think at a collective level, a societal level, perhaps something like that is going on. There are so many people who have been traumatized through the pandemic and whose trauma is live and ongoing. There are all the people grieving the loss of their physical health because they're now suffering from long COVID, for instance. And if society isn't talking about that or even acknowledging it, that feels to me like a form of ongoing harm.
So I'd like to turn now, and building on this discussion about harm, to what I see as one of the key themes of Breathtaking, which is moral distress and moral injury among healthcare staff. And I thought I would read an extract from a British Medical Association report from 2021 about moral distress. And it says, Moral distress is defined as a psychological unease generated where professionals identify an ethically correct action to take, but are constrained in their ability to take that action. Even without an understanding of the morally correct action, moral distress can arise from the sense of a moral transgression. More simply, it is the feeling of unease stemming from situations where institutionally required behaviour does not align with moral principles. And it goes on, moral injury can arise where sustained moral distress leads to impaired function or longer-term psychological harm. Moral injury can produce profound guilt and shame, and in some cases also a sense of betrayal, anger, and profound moral disorientation. And it's also been linked to severe mental health issues. So I'd like to talk about these issues, but I thought before that, let's watch a short clip from episode 1.
I know he has no travel history,
Right.
but there is the highest index of clinical suspicion that this is an undiagnosed coronavirus
Absolutely,
case.
Debbie, but the guidance says with no travel history, we can't authorise testing.
But I was just standing there watching a patient playing a game on his phone with his sat sitting in his boots, so the guidelines need to go in the bin for a moment.
We have to follow guidelines. We have no choice.
You know this thing is spreading all over Italy.
This is national guidance, OK? It's from Public Health England.
Thank you. I think that clip just, yeah, it kind of gives a taster, I suppose, of the ways in which moral distress and moral injury kind of run through, clinical care in the way it's portrayed in Breathtaking. And I wonder if you could talk a little bit more about that and your experiences of having to go through that.
Absolutely, Lucy. I mean, the starting point for me for moral distress in healthcare is the motivation with which everybody goes into working in a health service, whether you're a doctor, a nurse, a healthcare assistant, a paramedic. We all do it for the same reason. We want to help people. We want to help vulnerable people, people who are patients, who are suffering, and we want to do a good job. And we have magnificent training in the NHS to help us do a good job. And then to be flung into situations where the systems pressures around you prevent you from doing the one thing that you set out to do in the first place professionally and are trained to do is just so corrosive and painful as a clinician. I mean, we have it even before COVID, before the pandemic began. Moral distress was rife just because of conditions of hospitals, of the NHS being overwhelmed. But of course, COVID just heightened that to a terrible degree. And the kinds of moral, the kinds of incidents that caused moral distress are almost at the smallest end of the scale, the clip you just witnessed. At a more extreme end of the scale, they were things like knowing that we had patients who in ordinary conditions would get a ventilator in intensive care. But now, because there were so many people using those ventilators with COVID, we didn't have a ventilator to give them, and they were dying when, had we not been in pandemic circumstances, they might have lived. And even the distress that came with operating daily with PPE was terribly distressing. So it's so important when you're providing healthcare, not just to be a sort of diagnostic and treatment machine, to be healing and to be therapeutic in your relationship with patients. You need to be humane and compassionate and show your patients that you care about them. And it's so much harder to do that when there are barriers of plastic and masks in front of your face. So there were unimaginably traumatic conditions at work where we, through no fault of anybody's, felt as though we were falling short of the job we wanted to be doing for patients. And it was desperately traumatic for many, many people. At the time, I encountered colleagues who felt suicidal with the daily distress of not being able to do the job they wanted to do for their patients. And since 2020, there's been if you look at the statistics, there's been an enormous surge in post-traumatic stress disorder, trauma, anxiety, depression, and suicidal thoughts amongst healthcare staff, which is an absolute tragedy, and of course demands, or should demand, a really robust response from the government. These are people who so keenly and determinedly went into a dangerous situation at work to help patients. The very least we should be doing is supporting them. And I was absolutely heartbroken last year when the funding for COVID wellbeing and mental health hubs in the NHS was cut. So all those hubs are closing now. Over half of them have already closed, and staff can no longer access that psychological support. It's led to this sort of bubbling distress that's so close to the surface amongst my colleagues, people across the NHS, where if you talk to them even for a moment about what it was like for them working on the front line with COVID, almost without fail, I find people start to cry. They start to become emotional because it's still so raw and painful for them. And I think for me, that was another powerful motivation for wanting to make the series. I just desperately wanted people to know what staff had given of themselves during that terrible time.
And I've seen that, you know, some clinicians saying it's too soon for them to watch it, but still being so glad that it's out there and that someone's made it to tell their stories that people may not have known about or realised the extent of from the mainstream media. Just a few stats on mental health as well, because I wanted to bring that up and kind of re-emphasise it. So there was a 2022 study by King's College London that found that NHS healthcare workers experience post-traumatic stress disorder at twice the rate of the general public. And actually 1 in 5 healthcare workers meet the threshold for diagnosable illnesses like depression and anxiety. So it really is a huge issue. Another survey in 2021 found that around 60,000 NHS workers were living with post-traumatic stress as a result of the pandemic, and 9 in 10, so 89%, said it would take many years for them to recover from the pandemic. So as you say, you know, this is a huge issue facing the NHS now, isn't it?
Absolutely, absolutely. And if we, you know, if we want a functioning NHS, the NHS is not beds and hospitals, it's staff. Fundamentally, it's the staff who are doing the caring, and we need healthy staff to be able to do a good job of caring for patients. So any attempts to invest in trying to support staff through this traumatic fallout of COVID isn't just a humane and decent thing to do. It's a practical thing to do for the future of the health service.
Let's watch another clip now. So I think one of the really powerful features of the series is the way you convey the very kind of claustrophobic and anxious atmosphere and what that was like for hospital clinicians. So I wanted to watch this clip now, which gives, I think, a taste of that atmosphere. Thank you, Katrine.
DOB, further 1265, picked up from Heathrow, blue light is here.
Get ready to
airway
move.
Open, no airway.
Ready,
steady, roll, 40 p.m.
Ready, steady, online.
Let's make some room.
It's completely abundant.
ABG, please, and can we get some monitoring?
Yeah.
Do we have access?
Just a peek, he's completely shut down.
Not shifting much air.
Okay, can we get an urgent chest x-ray in here, please?
On the way. Crept throughout. Neil, do you have an airway?
Yeah, but I'm having to help. SATs are in the 70s.
Okay, he's tiring. We need to get on and intubate.
Yeah, agreed.
Drugs from the fridge, please. Joe.
SATs are 52.
barely breathing now.
Suction, sir.
All right, are you on their way?
On their way. Okay, drugs going in. Boozy ready, please.
We're going to need the ABG as soon as you can, guys.
I'm going to need suction. Tube, please.
He's arresting now.
It's really quite tough watch there, and I apologise if anyone was shocked or not expecting to see that scene. I think one of the important reasons why those scenes are so necessary, though, is that it also, and throughout the series, I think this is the case, you really get a sense of the justified fear that clinicians were operating with on a daily basis. And obviously there's a storyline with the ward nurse who dies of COVID as well. But I wonder if you could talk a little bit about that fear, because I think that is the aspect that it's quite hard for us non-clinicians to sort of really understand how you cope with doing your job in that context of fear and uncertainty.
Well, I mean, I can remember vividly how afraid I felt at the start, and it's hard now to put ourselves back into early 2020. But remember, at that time, we had obviously no vaccines, but we didn't even have any treatments. The only treatment we had for COVID then was oxygen. There was nothing else that we knew worked. And what we were seeing coming out of China initially, and then perhaps most vividly out of Italy, because that was very much on our doorstep. It really felt like it was now arriving in Britain, which of course we subsequently knew it was. It was absolutely horrifying to see. And I vividly remember the first time I saw and treated a COVID patient, and it's the first time in my professional life as a doctor that doing my job has potentially put my life at risk. And I was very aware of that. I was aware of the fact that my PPE was not what we've just seen in that scene. It was a paper mask that didn't fit terribly well and a plastic pinny. And I remember walking towards this patient sort of simultaneously, every fibre of my being wanting to help. He was distressed, he needed help urgently, but at the same time, a little bit of me inside wanted to recoil because I was frightened of his breath. Every time he breathed out, he could be infecting me with a virus that I would then take home to my family, my children, my husband at home, all that would infect me. And of course, by the time we in the UK started treating patients with COVID, the first doctors, nurses had already begun to die. And of course, they were catching the virus on their wards. So it was frightening. And although the public response to what healthcare staff were doing, talking about us as heroes, was incredibly moving and meant so much to me. It was amazing to feel as though the public was behind us. Of course, the truth of the matter was we were not heroes. We were every bit as flawed and fragile and filled with good points and bad points as any other human being. So I wasn't kind of heroically brave. I was scared and went towards that first patient despite my fear. And I think that's simply what everybody did, because in a crisis, if you are trained to help, then you desperately want to use your training. I'm thinking now of all of those incredible firefighters in New York in the time of the Twin Towers terrorist attack, and how they literally went into those burning buildings, and some of them never came out alive. What astonishing heroism. And yet there's something about the moment that means you step up. You have to, and I think that most people are like that. I think in a crisis, when we can see vulnerable people around us who need our help, I actually think most people are brave. And I know that my friends who were furloughed, who were on lockdown, that the thing that they felt most guilty about was not being able to help. And I remember feeling almost gratitude that I had a job to do, even if it was frightening, because it meant we could try and help. And I think that's a universal human impulse, maybe not everybody, but most people.
Yeah. So you already touched on the next topic a little bit, but I wanted to talk about the impact of the pandemic on communication and how you communicated both as a team, but with patients and their family members as well, because it's obviously such a key aspect of being a good doctor and providing good care, being able to communicate well. And it was so critical to families as well, of course. And I actually found some of the communication in Breathtaking really powerful and kind of, yeah, just very humbling to see clear, compassionate communication. I wanted to show another clip here. This is the last clip that we'll be looking at. Could you please put that on, Katrine?
Then the CPAP machine pushes air into your lungs for you.
Will it hurt?
I'm afraid it can feel quite aggressive, quite claustrophobic, yes.
And if I don't?
Archie, I want to be completely honest with you. Without CPAP, I'm not sure you can survive this.
I mean, I'm sure you had to have many conversations like that. And I'm sure that with time, you probably worked out a way of having them, and you were drawing on all of your palliative medicine training in doing that. But I wonder if you could tell us a bit more about that aspect, the kind of communication with families and with patients.
Yeah, well, in a way, I'm I'm unashamed to admit, although I'm not sure I have admitted this in public before. So you have a groundbreaking first, Lucy. I had a secret agenda in making Breathtaking and writing the scripts, which was I realized we had this incredible opportunity. This was a television series that was going to be watched by millions of people. So I saw it as a kind of secret renegade chance to bring what's important in palliative medicine right into the script at every opportunity. And it was incredibly important to me that those many, many conversations around life and death and people's wishes were right there in the forefront of the series. And there are other little details, like the fact that people above their beds had a little sign with their name and what mattered to them, because what matters to an individual patient is very much at the forefront of palliative medicine. But those of us who work in palliative medicine passionately believe it should be at the forefront of medicine across the board. So I think when we were all having those conversations, it was almost an extremely difficult version of the kinds of conversations that happen every day in a hospital, and arguably should be happening more in a hospital. And you can see in that little clip, there's two things beautifully illustrated. So Jo Froggatt, the wonderful actress who conveys so much compassion simply through her eyes as her face is masked, she's doing two things there simultaneously. Well, maybe three. She's speaking in clear language. There's no jargon in what she says at all. It's easily understood by the patient. She's being completely honest. She's not sugarcoating anything. She's not glossing over or using vague, opaque language to explain the stakes of this situation and what might happen if Archie, the patient, does not have the treatment CPAP. But the third thing she's doing is she's simultaneously saying something that's very bleak. Essentially, I think you may die without this treatment, while conveying immense compassion and care. She is utterly focused on her patient. It's as though he's the only person in the room. Nothing else exists for her, the doctor, in that moment. And I think that tenderness and care and attentiveness help make him feel cared for, even though he's having to hear something very, very difficult at that time. And I think that's what we all strove to do. We were so often having to communicate facts that were bleak, that somebody was beginning to lose their fight against the virus, or we were phoning relatives and having to say that their loved one was beginning to die. And these are really difficult truths to tell, but if you can communicate them with sincere and absolute focus and kindness and compassion, then that helps. And there's a wonderful quote by the American poet Maya Angelou, who famously once said, "People will forget what you said, they'll forget what you did, but they will never forget how you made them feel." And that could have been the mantra, I think, for the communication we tried to give during COVID. There was so much beyond our control, but you could control how you communicated with patients and their families. And if you could bring humanity into those conversations, then you were managing to do a tiny little bit of good in a very bleak set of circumstances.
And one thing I wondered, I mean, obviously, you know, we've talked about the hugely detrimental impact of the pandemic on NHS staff and on the mental health of NHS staff in particular, but I wondered whether the pandemic had changed how healthcare staff communicated, or perhaps whether kind of non-specialist palliative care clinicians might have learnt more about the communication skills which you as a palliative care specialist might use through that process.
Yes, and I think strangely that is perhaps a positive to have come out of a very dark time. What if you look back on those 18 months now, we had such fundamentally important pillars of compassionate healthcare suddenly taken away at a stroke. The family member, the loved one at the bedside was taken away. So in the main part, visitors were not allowed, although they were increasingly allowed in end-of-life situations. But patients lost the incredibly humane part of their hospital experience that is provided by a loved one close to them at the bedside. And then simultaneously, we had all of those physical barriers of the PPE, the infection control measures between us and our patients, making it harder to communicate. And staff found both of those things exceptionally painful. They felt like an inversion of everything that should be happening when patients' lives are at risk. The one thing you want in that situation, if somebody is dying or knows they may die, is as much humanity as possible. You want to help your patient not feel alone, help them not feel frightened. And how do you do that if you are barricaded behind these layers of PPE? And I think that was simultaneously traumatic, but also a kind of shock education in what is really important. It is easy in ordinary everyday practice to forget just quite how important those things are, but take them all away in a stroke and suddenly staff are left horrified by their absence. And it was a way of galvanizing us all into realizing and remembering that these things matter. And if these things are not at the heart of healthcare, then we may be doing a good job of treating a diseased pair of lungs or an inflamed liver, but we are absolutely not doing a good job of treating the human being who is our patient. So I think that everybody, whether they worked in palliative care or any other specialty, learned something very, very profound and lasting and important. And I think that endures. I think, unfortunately, conditions of practice in the NHS remain really, really tough, and it's very hard to deliver that care if you don't have enough time to see all of the patients who need your attention. But staff know how important that is, and it's endured for everybody.
Yeah, certainly. And obviously another key theme in Breathtaking is the impact on patients, close people like their family and their friends. And, you know, we've been doing a program of research on bereavement during the pandemic as well. So it's a subject very close to my heart. And I know lots of the people in the audience are also were bereaved during that really difficult time. I suppose looking back on how things were then, what's your perspective now on sort of family experiences and friends experience? Because you've had all this time thinking and talking about the impact of these things on people, haven't you?
I think, honestly, Lucy, for so many people, it was shatteringly painful and shatteringly traumatic, because these moments in people's lives that really matter, you know, births and deaths are obviously immensely important moments. But if you think about all of the important moments, so people's marriages, finishing school, going to university, you know, getting divorced, or all these milestones in people's lives, we tend to celebrate or commiserate over, mourn over collectively. We're not creatures of isolation. We are communal creatures. We love to live our lives with other people. Mainly, most people are like that. And the normal rituals of grieving and of mourning and trying to piece yourself together again and find a way to live with grief after a bereavement were just savaged by COVID. And it's not that I think the rules and regulations were unnecessary. We were in a time of crisis, and trying to restrict avoidable social gatherings and social mixing, of course, was necessary in a serious pandemic. And we are, of course, still in a pandemic. It hasn't gone away. It's diminished. It's still there. But nevertheless, they were savage for people. And I have met and talked to so many people whose grieving process has been complicated by the fact that the funeral took place on Zoom and not in person, or perhaps that they were not able to come into hospital to see their husband or wife of 50 years because they too were in their 80s or 90s, and the risk of them catching COVID was just too great. And then not only were they not able to see their loved one to say goodbye to them, then they had to sit at home by themselves because mixing wasn't allowed. And all of these things are just an inversion of the rituals and the communal support and the kind of collective throwing of arms around a bereaved person that many of us so desperately want to provide because it helps. We typically find living through traumatic experiences that little bit easier if we're not alone and we have people supporting us. And I think that is another aspect of the pandemic that has not been publicly acknowledged anything like as much. It saddens me that we don't have a almost government and sort of society-led National Memorial Day. I know we have a day of mourning, but it's not, it's nothing like, for example, Remembrance Sunday and the Cenotaph. I simply do not understand why, as a society, we devote more care and attention to memorializing and paying tribute to people who gave their lives in times of war, the First World War and onwards, on Remembrance Sunday, and yet there is nothing or next to nothing at the moment for the collective upheaval and trauma and loss that we all went through in the pandemic.
Yeah, I think many people on this call will agree with that. I think it's such an important area. And you mentioned the sort of social isolation. It was almost like this double whammy, wasn't it? The sort of the trauma of the death itself often, and then compounded by the social isolation and loneliness, which people experienced afterwards when they were unable to see people or be comforted or do any of the things they would usually have done to cope with a really awful grief experience.
Yeah.
So there is a lot that still needs to be understood and more support that needs to be available for bereaved people, definitely. We're going to turn to questions shortly, but before we do that, I just wanted to ask you about your reflections on how Breathtaking has been received, really, from the public, from bereaved people, from clinicians, and your reflections on the whole experience, because it must have been a very intense for you as well, kind of having gone through the last weeks and months of Breathtaking.
Yes, well, it's been 3 years in the making. We first started talking about the series and writing it, trying to write it. It took a long time, 3 years ago. And for a lot of that time, it never really felt like it was going to appear on anybody's television screen. And then all of a sudden, as it was rushing towards us, the transmission date, I felt unbelievably anxious about whether we had managed to achieve what we set out to. Would this ring true for staff? Would nurses, doctors, family members watching it feel as though it captured accurately and authentically what that time was like? And I was really anxious because I so desperately wanted to get it right, and I wanted staff watching it to say, yes, that's me. That's what it was like. I feel as though I'm being seen and heard now. And wonderfully, that was the reaction from staff overwhelmingly. They and the messages poured in from every direction from staff members saying, essentially, thank you to the production team for putting their story on screen. Many people felt it was too traumatic for them to watch, which just shows, Lucy, what we've been talking about, how very raw and ongoing the trauma is for staff of COVID. But at the same time, many staff members watched it and said, it was painful and traumatic, but I am glad that I've watched it. And some hospitals have actually contacted me to say they've held group reflections and discussions among staff about the series, and they've actually talked about what their experiences were like in a way that they haven't done before, and that means a lot. And then from the wider public, there's been an incredible outpouring of responses. Again, many people traumatized, but still watching and saying, my relative died in April 2020, and this was really hard to watch, but it needs to be out there, and thank you for showing it. So that has been incredible, and I think in a way that's the thing that I will forever take away with me and feel proud of, because I just wanted to try and show this story truthfully and honestly on screen, and I hoped that in so doing we might have a almost a national conversation, a conversation about what it was like. Let's talk about it. Let's not pretend it never happened. Let's actually look it in the eye and talk about it, because we can't learn any lessons if we're too afraid to confront it.
It's certainly true. We're going to turn to the questions now. So we've got lots of questions here, and I'm going to do my best to go through some of them anyway. The first one, so several people have asked this, so how do you cope with the ongoing toxic comments on social media from COVID deniers, especially since the TV programme?
Yes, well, this has been an ongoing theme since 2020, and It's not that I'm used to it. It's not that it has no effect, but I think I have, as the years have gone by, I've got a kind of clear response in my head to the abuse, and there's still a lot of online abuse, and since Breathtaking was aired, it's mutated into a new form, which has been a lot of the online trolls claiming that I'm literally not a real doctor. I am in fact an MI5 spy, which, you know, is ludicrous. But I think if I find myself getting upset, and occasionally I do, I try to remember that that is exactly the intent behind the trolling. They want you to be upset. They want you to keep your head down. They want you to stop speaking out and telling the truth as you see it. And if I'm upset, in a sense, I'm giving them exactly what they want. And so I try and remember that, because it helps me have perspective. And I also try to remember that if somebody can be bothered to write a sort of toxic tweet or abusive message on social media, it's because you've made them angry. And you've made them angry because you have presented something to the public that is honest, is as true as you can make it, and it undermines the misinformation about COVID or vaccines or the NHS that they want people to believe. So perversely, the trolling goes hand in hand with, for example, Breathtaking, the television series, having an impact and getting people talking. So I try very hard to compartmentalize it in that way. And I also quite like to remember, I have this this image of your typical troll on Twitter, and they're and I'm sorry because this is going to sound sexist, although there's a lot of misogyny in the trolling. I imagine a kind of man sitting in his underpants, tapping away very angrily late at night on his keyboard. And fine, if some people feel the need to do that, okay, but I know that the overwhelming set of responses is positive and wonderful, and I'm definitely going to care more about them than the men in their underpants.
That's a good, great coping strategy. I'll remember that one. You're also getting a lot of love in the chat, and I will copy the chat and send that to you so you can read it afterwards. There's a few questions around speaking to the government and also trust in the government. So Kate asked, any trust that NHS staff had in the health authorities or government must have been undermined. Is anything being done to rebuild that trust so that the service as a whole can begin to heal?
Well, the short answer, sadly, is no. Their actions always speak louder than words in politics, and so a good example of something that was positive was the setting up of the mental health and well-being hubs to support the psychological health of staff as we went through COVID. That was a meaningful, positive act that helped staff feel supported. Obviously, pulling away the funding for that last year has the opposite effect. But I think that the hardest thing, or one of the hardest things for many of us, was that those early few months of the pandemic, when there was a gulf between what the government was telling the nation and what we knew to be the case from our position as frontline workers. And of course, PPE was one of the most controversial scandals. So we would have figures from the government standing up and saying categorically there are no national problems with PPE, when we had staff having to wear scrubs made by local charity groups, visors made by school children, masks that had been delivered by local veterinary practices. The PPE just wasn't there, and staff were woefully inadequately protected, and many staff lost their lives as a result. And the trouble with trying to pretend to the public that that isn't the case is that it makes staff feel incredibly frightened, because we know we've been kind of thrown to the wolves, and B, it makes them feel very angry because they feel as though they're completely expendable, they're just cannon fodder. And that's really what it felt like. We obviously were not going to be adequately protected. We still, the irony is, if anyone had asked us, we're sorry, we've only got these paper masks, will you still go and do your jobs? I think most people would have said, yes, we will. We understand that you don't have a stockpile, there's a shortage of these masks. We still want to do this. But to be lied to about that just shatters all trust. And trust, when it's lost, is really hard to rebuild. If during the National COVID inquiry, people such as the former Health Secretary, the former Prime Minister, were honest about these things and said sorry to healthcare staff, that would be an incredibly powerful way to rebuild trust. But that hasn't happened. They've doubled down.
Mm. And a few people have asked, have you been asked to give evidence to the UK public inquiry?
I haven't, and I think that is absolutely right, because I am outspoken and I was very critical of some of the government decisions throughout the pandemic, and I think that means I can't be seen necessarily as impartial. And in fact, you know, I don't think I was impartial, in the sense that I was always trying to advocate as strongly as I could for NHS staff and for patients. So I think it's very sensible that I'm not part of the people giving evidence. There are, you know, there's 1.3 million people in the NHS and they can all give evidence. But I was very pleased when, after the first episode was broadcast, the UK COVID inquiry tweeted about the series and directed people to sources of support. And I hope that lots of people involved did watch it, because it was as truthful as we could possibly make it.
And this is from Karen. So do you think lessons have been learned, especially around the necessity at times to avoid following guidance, but doing what is best in the circumstances for a patient group or hospital setting?
That's a really tricky one. I think doctors especially we have quite a healthy skepticism towards guidance and protocols anyway. And in fact, you are taught as part of your medical training that a protocol, for instance, a guide to how to treat condition X, may usually be right, but there are always exceptions, and you should never lose your critical faculties of assessment as a doctor. And I think we definitely applied those faculties early on to the guidance that was coming out around infection control and PPE especially, and also testing. The rules around testing were very, very obviously being shaped by the lack of tests, not by what was good infectious disease practice, and we all knew that. So I think that left us all feeling, yes, more cynical about the national guidance and protocols that are meant to shape our practice. What's striking today, though, is the fact that to some extent, that mismatch between best practice and what the protocols say still exists. So COVID is still, we are still in a COVID pandemic, according to the World Health Organization. And in fact, it's still the case that around 200 people a week are dying of COVID in the UK alone. And it's also the case that if we are treating patients who are suspected or known to have COVID, usually the first line PPE will be a paper mask. It won't be a so-called FFP3 mask that's more protective. And I know that many patients who are clinically extremely vulnerable or have children or dependents who are very, very upset that there isn't better ventilation in hospitals and more extensive use of masks. And I think fundamentally that comes down to the fact that in 2024, as in 2020, the official kind of government and NHS England position on COVID and airborne disease is that it's not an airborne disease. It is spread by droplets, primarily by infection that you pick up from touching objects that the droplets have fallen on, and it's not. It's spread through the air we breathe in and out. So that is an ongoing issue, and I don't know how it will be resolved.
Mm. You've got a lot of work ahead of you, Rachel, despite all the work you've done, it sounds like.
Yes.
Thank you so much. We're going to bring the conversation to a close now. Before we end, I would like to ask a favour from everybody who's attended today. So at Good Grief, we've been running these events, free events on grief and loss and death and dying since 2020 to help normalise these kind of conversations and share knowledge and information. And if you have benefited from our events, we'd be really grateful if you could make a small donation to Good Grief. So Katrina's going to put the Just Giving page in the chat. So I just wanted to mention that before we end. And any donations will go directly to producing these kinds of events and help sustain what we're doing. And if you have already donated, thank you very much. Rachel, I was looking through Dear Life last night, and this Ted Hughes quote jumped out at me. The only calibration that counts is how much heart people invest, how much they ignore their fears of being hurt or caught out or humiliated. And the only thing people regret is that they didn't live boldly enough, that they didn't invest enough heart, didn't love enough. Nothing else really counts at all. And I love that quote. And I think I really see you as an example of someone investing all their heart. And I want to thank you from all of us for all your work as a campaigner and a doctor and all the beneficial effects you're having in the UK. So thank you.
Thank you, Lucy. That's lovely. Thank you very much.
And thank you all for coming today as well for this evening. If you do need any further support or you'd like more information following this session, please visit the hub on our website, and you can see the resources tab at the bottom for some more links. So thank you all so much. I hope you have a peaceful evening. Goodbye.